Welcome everybody to the National NBS Pilot Monthly Webinar to the November meeting. I know it's been a few months since we've had a break. Just remind everybody to keep yourself muted while others are speaking, but feel free, this is an open discussion. So if you have any questions, feel free to unmute yourself or you can also type something in the chat box as well. And finally, these calls are recorded and they will be posted on the NBSTRN YouTube site. So we'll continue with our normal standing agenda. Is there anybody that is new to these calls that would like to introduce themselves? I will take the silence as a no. So we will continue with getting updates from the pilot study teams on their active or completed pilots. And we will start with the New York group first. And I know Colleen is on the call. And Colleen, you can go through the list, start with whatever condition you want to start first. What our last meeting was in August. So this is the information in August and you can just update us on what's new.
Okay, well, I couldn't remember when the last meeting was, so I'll just give you a total update. I'll start with SMA, since that's what you have first. We've now screened about 660,000 infants. We are up to 34 referrals now, so 2 since August. And interestingly, one of them actually only had 1 copy of SMN2. It's the first time we've seen that. Obviously, this baby is very sick. The last update we got was that the baby had profound weakness, several other health problems, and hadn't started treatment yet, but they were planning on starting Spinraza. ALD, we've screened about 1.9 million. We're up to 134 referrals. And 41 diagnosed with XALD. Ante, we're at about 1.65 million. With 194 referrals, so that's 4 since last time. 2 of them were carriers and 2 were possible late onset. So that's added to what we had last time.
Mm-hmm.
Okay, NPS1, we've screened about 660,000. We're up to 33 referrals. Still no confirmed NPS1, and still only those same 5 possible late onset cases with 2 variants. So the new ones were all carriers.
Keep on moving. I'm just making
a little.
Yeah.
Okay. And Dr. Tavicoli gave me an update on the DMD pilot. The recruitment ended on September 30th. So between October 1st, 2019 and September 30th, 2021, 36,548 infants were screened. 42 infants were referred. So as in August, those same 4 boys confirmed with DMD, BMD. And So the pilot's basically just finishing up now. There's some repeat specimens that were requested that are kind of trickling in at this point. So they're wrapping up that data.
And I'm
And
guessing,
then pardon me?
no, I was just guessing that you're still gonna wait. You're gonna also have sequencing and stuff that probably needs to.
It's gonna, yeah, right, still come in on anything that screens positive.
Mm-hmm.
GAMT deficiency, we're up to 660,000 infants screened, but everything else is the same. We've still at 25 referrals and still only 1 true positive. So no changes since August.
Is there any other questions for Colleen about the different, well, most of these are now the only one, DMD is the only pilot that's just completed and everything else is active on the panel, correct?
Correct.
Mm-hmm. Any questions for Colleen? I'll take the silence as no questions at this moment, but thanks, Colleen.
This is Dr. Friedenberg. I don't know if I've managed to unmute myself, but I have a question on the GAMT. Of the 25 referred, were there any other diagnoses made in those kids, or were they all just false positives with no other clinical diagnosis?
We haven't been notified by any of the providers that there was any other diagnosis on those babies.
Thank you.
Yep.
That's a good question. Yeah, I'm not sure if there's with GAMT deficiency with that analyte, is there any other expected things that you might find? I'm sure if you know, Colleen, if you're expected to find anything else with that testing method.
I don't know if, I think Joe wasn't going to be able to be on the line. He might be a better one to answer that question.
Colleen, this is Marilee with the Kansas Newborn Screening Program. And on your LSD disorders, Pompe and MPS 1, do you report to the doctors that it's possible late onset, or do you just let them know they're possible carriers?
So we report them, we refer them even if we think they're only carriers. So if they have a variant, we're going to refer it to the provider. And then they make the call whether they're going to consider it a likely carrier or possible late onset. I mean, as far as our categorization, if the infant has 2 variants, we're calling it possible late onset, but the physician sometimes comes back and says, no, they feel it's only a carrier.
So you don't necessarily differentiate between the two when you're referring it out?
Correct. I mean,
okay.
It's reported out as a single variant detected, if that's all we found. So we're presuming it's a carrier, but no, we don't. It gets referred and then the physician makes the final call.
Okay, thank you.
Yeah.
And Melissa Precy has a question in the chat box, and Melissa, feel free to unmute yourself because she asked what else could be picked up, but I'm not sure if that meant for GAMT or is that for the other conditions, Melissa?
No, that was for GAMT. As we were talking about it, I was having the same question that Debbie was having, so I was just wondering if anybody had any ideas about that.
Thanks. And then the other question I had for you, Colleen, since you guys are doing sequencing, you're doing sequencing for Pompe and MPS 1 and XALD, correct? And
Correct.
then are you reporting that to any databases, or is that up to the clinicians or for diagnostics?
Yeah, we currently are not reporting it to any of the databases.
Okay, all right, that's good to know. Any other questions for Colleen? Well, thanks again, Colleen. And if anything comes up, we'll let you know.
Okay, thanks.
All right, I'm going to move on to the North Carolina group. I think either Kate or Melissa was going to give that information.
Yeah, this is Kate.
Hey, Kate.
Yeah, so we just sent this information yesterday, I think. So
Mhm.
that should be all correct. So we no longer screen for SMA. The state is doing that. They launched in May, identified 5 babies since then, and working on adding XALD. For our DMD pilot study, we're at about 7,500 screen, 41 onset, mostly QNS. Based on our initial screen, we had 54 screen positives, and then we consent them for additional blood draw and NGS. So we had 33 of those consenting for repeat blood draw, and 1 had slightly elevated total CK, and the others were normal or are pending. There were 43 that consented to NGS. 1 was a confirmed a baby with the mutation DMD gene. That one declined the latent total CK testing, so we don't have data, total CK data for that baby. And we have 1 with autosomal dominant mutation CLCN1. And then there are 6 with other findings on the sequencing panel. And some of them are pathogenic carriers of pathogenic mutations, or likely pathogenic. Some of them are unknown whether those mutations are recessive or dominant. And that's it. And then maybe I can hand it over to Melissa to talk a little bit about our awards to screen for MPS II.
Sure, thanks, Kate. So as Jennifer has on the slide, RTI was awarded the NICHD IDIQ contract and the first task order to screen for MPS II. I guess some of the things to point out that are a little different about our approach for the MPS II task order is Kate was mentioning our DMD pilot and the SMA pilot were done through a consented model, whereas our XALD and prior MPS I task orders were considered public health practice. This task order, we're actually approaching it a little differently. So we are going to request a waiver of informed consent from our single IRB, which is UNC, who's our clinical partner on the project. And our hope is to actually screen for 140,000 babies in North Carolina with that waiver, should it be approved. So like the other task orders, we'll be working with the state of North Carolina to access the dried blood spot specimens. We also have a partnership with Duke to conduct some of the confirmatory testing. So I'll let Kate jump back in and talk a little bit about the approach from the lab side of things.
Yeah, so we're in the planning phase of doing this in our laboratory at RTI with mass spec approach. And there's not much else to say at this point, as we're just in the planning phase of this. And the goal is to screen 140,000 babies over the period of 2 years.
So we have a question from Lisa in the chat, and she had a question about the DMD pilots, and if you could comment on the follow-up, comment on what the follow-up is for the confirmed cases.
Yeah, so we the screen positive babies with the finding on the sequencing panel or elevated total CK, latent CK, see a physician at 6 months. And I'm not sure if Beth is on the call, but she would have up-to-date information about how many of these have been seen and I unfortunately don't have that handy right now.
And Colleen, if you can comment on what your pilot, what the New York pilot says doing, that would be great too. Or I think Nikki's on the line as well.
Yeah, I think I saw Norma on the line. She might have a better idea.
This is Nikki, or Norma's welcome to jump in if she wants, but the identified diagnosed babies are followed through the neuromuscular clinic at the reference institutions. So they're followed through a multidisciplinary neuromuscular center.
Well, congratulations, North Carolina RTI, on the new task order. And do we have any other questions about their DMD pilot or the MPS 2 task order?
Yeah, this is Dr. Friedenberg, and I just had a question about on the DMDs that on the CPKs that are initially elevated. So when you go to the next gen sequencing, are you doing a full panel, a myopathy panel, or is it just looking at DMD, or is it even broader than that when you go to the second-tier DNA screening?
It's a larger neuromuscular panel. I don't know the number right now, but it's 58-ish genes that are on it. So that's the 6 non-DMD in our count, and the 1 CLCN1 pathogenic mutation. That's all of those are from the sequencing panel.
And then I guess I have one other question that you probably can't answer right now. So do you know on your sort of false positives, the one that were the ones that were tagged for follow-up, do you know if those babies had like difficult vaginal deliveries where you might expect a little higher CKs, or you really haven't tracked that?
Yeah, so we're trying to track that as well as we can. So our genetic counselor, when she reports the results, she asks that, but it's a little tricky to get that information exactly correct. But we know that we do have some difficult deliveries that have elevated CK. Yeah.
Does the New York team want to comment on the same question?
We're not following the birth trauma in the pilot, but I think for the latest information on the pilot and the algorithm, I saw Lisa Feuchtbaum had a question in the chat window. You can review Norma's talk at the APHL symposium, or drop us a note and we can send you some details, or link directly to that presentation.
How is it, so and then also the sequencing question, as far as after the child has high CK-MM, is it a larger sequencing panel, or are you just sequencing for the DNA?
Start with a panel of, start with just the dystrophin gene and look for deletions and duplications, and then sequencing of the gene. If nothing found, then goes to a 46 gene panel. If nothing found, then goes to a 90 or so gene panel.
Yeah, I know that on the previous call they have reported out. I think we're just discussing the 4, but I think on the previous call, I believe Nikki has reported out some of the other findings that you've had in that pilot besides Duchenne or Becker. So any other questions for the North Carolina team? In particular about the plan for the MPS 2? Is there a timeline that you guys have that are targeting, Kate or Melissa?
I'm going to comment on the DMD. So we have 86 genes on the panel. And we don't divide it up we just consent once for the entire panel, not which is a little different from New York. For MPS 2, the timeline is 6 to 9 months for startup period to get things in place and launch in the spring.
I'm gonna open it up for any other last minute burning questions. Be interested to see, what happens when you guys start this pilot too. This will just be a single enzyme, I guess, assay. You'll just be looking at MPS 2.
Right, yeah, so that's the plan
Mhm.
with some internal control TBD.
Gotcha.
Hi, this is Sandra, genetic counselor of Minnesota newborn screening. I think I have a question for New York based off of the fact that North Carolina's looks like it's reconsenting for the DNA portion for DMD. So for the New York team, are you waiting until the genetic testing is done before reaching out to get follow-up on your cases, or are you calling right after the CKMM test?
The pilot, this is Amy from NBSTRN, so it's a pilot for Duchenne. So the algorithm for the pilot is the parents are aware after a repeat, CKMM is still elevated. They don't have to reconsent for genetic testing, but they are aware once the first pilot, Norma's on the call too, she can jump in. But
she just posted something in the chat, and Norma, feel free to unmute yourself, that the gene panel is 132 genes.
That's right. So we initially do the Perkinelma CKMM, and then if that's elevated, and the baby's referred, and then the parents are contacted and they give consent for the genetic testing. And more recently, we've been able to get IRB approval to send dried blood spot to Perkinelma Genetics. So then they do they first do the DMD gene, and then they do the neuromuscular panel, which is 132 gene panel.
Thank you.
So Norma, do they do it from the same larger panel and just informatic selection and, another reporting from the same next-gen sequencing test?
Yes, they open it up.
Thank you.
So if there's no other comments, I'm going to move on to the Georgia group. And I know Angela's on the call already. So Angela gave you some updates, but feel free, I can add some more notes.
Hey, yeah. Let's see, what do we have? Oh, since we started from August, just so you know, we screened, this is number of samples, it's 41,200. Yeah, all samples screened, just so you have kind of a baseline of the numbers. 41,210. And that's from August 1st until today, just so we have kind of a time frame. ALD, we did have 2 positive screens. They're both pending, although I think one of them is going to resolve as normal. The other one, I don't know. They're not answering our phone calls. Let's see. SMA, we have one kid that's a legitimate abnormal and that we've referred over to the SMA clinic. We're waiting for them to see that kid and get all that confirmatory testing, but they've already ordered it. Let's see. Okay, MPS 1 in Pompeii went live in September. We did pilots way back in the day, and we are now live screening for those, going really well. I forget, what were the numbers I sent you, Jennifer, on the Pompeii? Did we have 2 positive Pompeiis? Is that the truth that I said to you?
I don't think I got the numbers for Pompeii and MPS 1.
Oh, okay. So MPS 1, we've had no positives, none, which is great. We're doing enzyme in-house in a combination with the clear tools. And then we're doing second tier on the dried blood spot at Mayo, doing GAGs. So it's going great. It's going much better than our pilot where we were not doing second tier testing. Pompeii, we've had, I believe, 2 positives, and I know one of them is definitely normal. I think one is pending, if I'm not lying. We are also, oh, go ahead.
Oh, I'm guessing this number is just maybe half or a little lower than your total.
Yeah, it's not all of that. Let's see. I can tell you that, yeah, you're gonna take out 12,400 plus another 6,000 probably. So yeah,
Minus 18,000.
probably roughly. Yeah, for that. But yeah, they're going great. We're also doing what I forgot to tell you. Sorry, Jennifer. I was trying to answer your email yesterday and I was like in 10 places. But we are also doing a pilot, a state funded pilot for Krabbe. I think I've mentioned that in the past. That started the same time as Pompeii and NPS1. That one is similar to NPS1, that we're doing enzyme with a clear tool, and then a second tier test also sent to Mayo for cycosine, and that is also going really well. We've had no positive screens, which is great. And then we finished our PUCD pilot, and we are literally putting the data together right now. So I don't really have a whole lot to tell you all other than we haven't confirmed any cases. We did have one kid who we were suspicious of. Kid had a legitimately elevated ammonia, something was going on, but we don't know what. The DNA panel for a variety of PUCDs and I think some other things as well was done, and it was negative. And so that child is being weaned off slowly from like a dietary treatment, and we're seeing how that child responds. So still kind of in a pending pattern. Yes, and it's going to take a little while probably to figure that out. But yeah, so we're trying to put all that together, and we will be putting a report to the NIH in January, I believe, is our end date. So we'll see how that shakes out. But literally, yeah, just looking at spreadsheets right now. Our expanded homocystinuria pilot, we are working on our strategy that was already a floating target when we put in the application for that. And we had some holdups trying to get the LSDs up and running in the lab. And now we're just trying to nail down exactly what that's going to look like, but hoping to get that going really soon. And then, yeah, finally, we did get, we applied for it and we were awarded the IDIQ contract. We did not apply for the NPS2 task order though.
So I think that the task orders, the contract now requires there's a task A, which is like core activities that should, yeah, I guess there's like a committee and.
Yeah, like for example, we just put a tiny bit of Bill's effort, Dr. Wilcox, who's the PI on the project, we put a tiny bit of his effort on that. But the impression was it's mostly to assist the NIH in sort of guidance in a lot of these projects. So we did, yes, we did put together that one, but not the task order for NPS2.
Well, thank you for that update.
Yeah.
Does anybody have any questions about the any of the new developments? You guys are very busy with lots of different pilots and starting to apply implementation as well. So any questions?
I have a question about turnaround time for your Mayo second tier tests. How is that?
It seems to be going well. Trisha may want to comment more, but I think they're running it twice a week. And
so for this is Trisha, for NPS 1, they're running it twice. I believe it's twice a week. So we batch them and we send twice a week. For cycosine, we send same day that it's reported as abnormal, and we're getting it back in 24 to 36 hours usually. So.
Any rough idea, Trisha, about how many samples you're sending over to the Mayo Clinic for each? Like what are screening that needs second tier testing?
I think we're around 1 a week for both, and we started out high and we're kind of tapering down to where I think we'll end up with probably about 1 every week or 1 every 2 weeks for each one.
Okay, sounds good.
Thank you.
Any other questions for the Georgia group? I will take the silence as no, but we look forward to hearing more updates about the Pompeii pilot and how that's going, and the homocystinuria pilot as well. And then the wrap up of the PUCDs. So you guys stay busy. I'm not sure if Wisconsin is on the call. May or Baker, are you on the call today? I'm not sure if I saw her. If not, I'm going to open it up to see if any other states have updates about some of the new developments in their state. In August, Florida talked about Pompeii and NPS screening, and we also got updates from Nebraska. But does anybody else, has anybody started screening for a new condition? Do they have any questions about some of the things that they've added to the pilot? This is an opportunity for you to let us know what's going on in your state. Anybody from Florida on the call or Nebraska want to give us an addition? I know we've had Maine discuss. Okay, well, I'll move on to some other updates, but if someone wants to jump in, just let me know and we can go back to you. I wanted, since we're in November, we're coming to the end of 2021. I wanted to discuss some ideas with you guys for helpful topics for 2022. I will be adding the meeting to people's calendars that have registered. We've been having conversations now for a year since I've been on the team about the IDIQ pilots and the conditions that I would say the newer conditions that have been added to the rest. So Pompeii, NPS 1, XALD, and SMA. I just would like some feedback from the group about, is it helpful to have discussions about these conditions? Is there outstanding questions about implementing these conditions or following these infants that have these conditions? I know that some questions have been asked about cascade testing. We've talked today about some of the genetic testing for these conditions. So feedback on continue just having discussions about this on this call. Of course, we would like to continue to talk about conditions that we're piloting. We know that NPS 2 is one of the new conditions that's going to be piloted for the IDIQ contracts. There'll be other ones, I'm assuming. Do we want to have discussions about things that have just been recently nominated, which is NPS 2, GAMT, and CRAB-A? Are there other potential speakers or topics that you would like to discuss? One idea that I was thinking about that I talked with in the newborn, the NBSTRN has a pilot research and implementation work group, and we've had many discussions about the definition of pilot study and what does it mean and what's the difference from a research pilot study or a state implementation or the pilot studies that are conducted for the IDIQ contract. So we can present as a group on a different definition and get feedback from the people that join this call on the actual definition of pilot studies. So I would like to just open it up for a couple of minutes to see if we have any feedback from people and see what they would be helpful to discuss. So I see Dr. Powell has written something in the chat, and feel free to unmute yourself. She said, helpful to discuss successes and challenges and short and long-term follow-up of these conditions. So are you talking about the conditions that were just added or these ones that are being nominated, or both?
The most recently added ones on the RUSP, I think, because some of them are somewhat challenging and, how to do the confirmatory testing and short-term as well as the long-term follow-up. And I think, just hearing from states around the country that have implemented these and any ideas for, how that's going, I think that would be, really interesting to hear about on one of these calls.
This is a great suggestion. So it sounds like maybe more of some clinical talking points more than it's been recently for the past year, and you guys can correct me if I'm wrong. It's been more technical laboratory focused, but maybe we should be mixing in some more clinical topics and is in the short and long-term follow-up realm.
I think one thing I'd love to see too, Jennifer, that builds on what Dr. Powell said is just what's the algorithm that states are using, not in the detail that we talk about the platform, but is it mass spec followed by a gene panel and the gene panel is done within the state or somewhere else? Like, I think we get a lot of questions on our state's sequencing, or are the clinicians ordering the sequencing? Who's interpreting the sequencing? So kind of figuring out for these new conditions, what's all involved. We know with, with SCID, there was the flow cytometry that became part of some states' algorithms and sort of the referral. So thinking about the discussion of DMD, when do you refer? What panel do you use? Who does the panel? Because the panels kind of dictate a little bit of what we find. Whether you do a 132 gene panel or 46, that changes dramatically the scope of the diseases you're looking at. So I think if we could get a handle on that, that would be great.
Thanks, Amy. That's a great suggestion. Does anybody have any other comments on that, or anything that they particularly would like to see as far as, or some question that you think we should be exploring more readily on these calls? So Joanne, she wrote on here, if states add DMD to their panel, do they have sufficient justification to check up to 100 different disorders, which is a good question. So more exploration on DMD is what I'm hearing too. And what
I think, Joan, yeah, I think, and that is for any other condition too. So do you look for just that gene? Do you look for a whole panel of related conditions? Where do you stop? Do you look in the introns? We had a talk in NBSTRN's research meeting from Dr. Walter from University of South Florida about an intronic mutation in SCID led to a whole change in how that newborn was treated. So looking beyond even exome sequencing, to other changes within the genome. So I think that would be interesting.
Oh, her mic isn't working, but yes, she says, yes, it frames as familiar as a family of conditions, neuromuscular versus one condition. So that's a good point too. So panel, adding a panel of conditions versus a single condition at a time.
Jennifer, I know there are some activities that APHL is doing that might be informative to this group too, that you're on the conditions counting task force or whatever you guys are calling it. Like, what do you call a condition? How many conditions are there? I think, Joan, that's something we struggle with too, is, we know the conditions that are on the RUS, but then a state might call the hemoglobinopathies 3 conditions or 70 conditions. So how do you even represent what people are doing? I think would be helpful, or not that we would take on that job, but maybe Jennifer, like we could work with APHL and see if there's anything they're doing in their groups that they think could be informative for this call.
Yeah, I agree with that. And I don't know who's on, if someone's on the from APHL is on the call, please unmute yourself and speak up. But yeah, I think those conversations are extremely interesting, and it's going to affect a lot of different groups, because when you look at different state websites, you think people are screening for very different things or very different numbers of things, and in reality, we're much closer than we're farther apart. So conveying that message to the public is something that has been challenging. is anybody from APHL on the call? Is there something that is there maybe topics that people might think that APHL and NBSTRN can tackle as a team approach?
Hi, Jennifer.
Hi.
Hi. Sorry. Yes. So that is something that we could discuss with Gisu. She's leading she's leading the group that's doing a condition counting. So we could possibly set up a separate meeting to discuss this.
Sure. We can actually, yeah, sure. We'll definitely be open to discuss that with Gisu or anybody else on the APHL team that might want to, it might be something, because there's you know, there's things that you guys, I know you have the new condition, also the new condition work group team as well, where you discuss a lot of the technical challenges with Pompeii and MPS1 and XILD as well, and SMA. So there might be some overlap in that with that team as well.
Okay, yes.
What about the topic of how states interact with researchers and possibly consenting blood spots or maybe even data as well for research? Is that something that would be a topic of interest? And what newborn screening's role is in research, or how researchers get in contact with them?
You know, one thing we could do, Jennifer, too, if people are interested, is maybe as the HRSA projects that are focused in long-term follow-up, data collection and care, I guess, involving state programs, maybe we could get in a few months an update from some of those programs if we think there's some overlap.
That would be great, yeah.
This is Stan Shortino from California. I was wondering if other states have biobanks, and we could discuss biobanking, which would relate to how specimens are used and consented, you know.
That's a great idea.
Yeah, or maybe some states are interested in starting biobanks.
Yeah.
The budget, but yeah.
Everybody wants biobank. but what do you do with it once you get it? So, I mean, there's a lot of questions that come up. So
yeah. And
legal and other type questions.
Right. There are a lot of legal issues. And this is Lisa Feuchtbaum. I work with Stan, and yeah, through the APHL work that I do, I've become aware that there's an outstanding case going on with, I believe it's the Michigan Biobank. And, you know, that it's really has a lot of implications for use of blood residual blood spots for research. And so I think there's a big area. I haven't been keeping up to date except for the little updates I get from APHL, because I'm on the steering committee with that group. And I think there's more to discuss, and there's just there are some legal challenges underway.
And it's a good point. And Ed Goldman is the chair of our NBSTRN Bioethics and Legal Work Group, and we just got an update from him last week on the Michigan case. So we could even have him come and present as much as he can, you know, wearing two hats, if that would be helpful.
I think that'd be great. I'd love to kind of figure out a way to get a regular update on that case, because it's really hard to track it, you know, when we're in the middle of doing so many other things. But I know that there's, you know, it's a challenging case, and it may not be moving in the favor of newborn screening and the storage of specimens. That's the latest I think I heard.
I mean, and then biobanks can, you know, come up with some policies where we can protect ourselves from such cases, you know. So I don't know where that falls, but it's worthwhile discussing.
So this is Debbie Friedenberg, and at the APHL Newborn Screening Symposium, one of the attorneys from Michigan involved in the case actually did talk And I assume if they talked on the national forum, they'd be willing to talk to this group if somebody wanted to contact them.
Yeah, we can reach out to him. Ed's on that team too, Debbie, so we can close that loop. The last I heard was that, you know, part of what Michigan has done through the BioTrust is make sure that families have a way to recall their consent or, you know, for the use of the dried blood spots, and they've published that. So that's part of one of the things that the case is, you know, pointing out is that if you want your dried blood spot not to be used, you have a mechanism to remove it from use. So, but we can definitely schedule him to talk, and that fits into, you know, part of what we try to reflect with APHL's great work of collecting data is, you know, how long do states store dry blood spots? What conditions do they store them in? You know, because some of that is important for researchers to figure out which states to go to if they may store them for 10 years or 5 years. And we don't always have the most up-to-date information. So part of what Jennifer's trying to think through is how do we make sure that the data at APHL and at NBSTRN is as up-to-date as it can be? And then what do you guys consider storage? What do you guys consider research? What do you guys consider long-term follow-up? Because some of those questions we reflect, do states say they're conducting long-term follow-up? We say yes or no on our website, and we don't know really what the definition of that long-term follow-up is. And so we want to figure out a way to reflect the great work that you guys are doing in state programs, but yet not also overstate it or understate it, depending on what you're actually doing.
Makes sense.
Well, if there's not any other if there is any other suggestions, feel free to reach out to me or Amy with things that you might want to hear. We things that you think we should cover during this meeting. There might be some surveys that will roll out at the end of the year just to see how you've liked this year. Any suggestions for, and then any suggestions that you think that we should incorporate for next year. I just have a few announcements, excuse me, from on the NBSTRN side. And if anybody else has any announcements, feel free to unmute yourself as well. Just want to remind everybody that the ACMG annual meeting is going to be held next year in March 22nd to March 26th. If you would like to submit an abstract, abstracts are due on November 19th. And this year, the meeting is going to be a hybrid of virtual as well as in person in Tennessee, Nashville, Tennessee. And then if you haven't already, please visit our website at nbstrn.org and sign up. Once you sign up, you can explore some of the tools that we have on our website, such as the LPDR, as well as get information. We have a newsletter that is sent out, I think, every month. From our group. We have lots of different social media resources where you guys can stay connected with us, as well as we have started a podcast called Newborn Screening Spotlight, where there's episodes that are released, and the newest episode has just been released on Duchenne muscular dystrophy with Dr. Michelle Lloyd-Purrier. So does anybody else have any announcements that they would like to add to this call before we close out? If not, I'll give you a few minutes of your time back. Our next call will be at the end of the year, December 2nd at 2 p.m. Eastern time. And then I'll start scheduling calls for the 2022. So thank you everybody for joining, and I will see you next month.